Hi, welcome back to Psychology 2. Now we're going to look at therapies. Now the therapies chapter is related to the previous chapter on psychological disorders. So on the surface, clinical psychologist K. Renfield Jamison seemed to have it all. She's a good-looking person, she has plenty of friends and a supportive family, and a promising future as a psychologist. She was bright, energetic, vibrant, and gifted on the surface. Sometimes, though, Jamison was too bright, too energetic, too vibrant. And then sometimes she was not. She was the opposite. In fact, depressed, lethargic, wilting in an abyss of pain and nothingness. Jamison knew the details of her illness. Jamison knew the details of her academic specialty, mental illness, far too intimately. She was bipolar. In her 1995 memoir, An Unquiet Mind, Jamison, a psychologist and professor of psychology at Johns Hopkins University, recalls her struggle with a debilitating mental illness that threatened both her livelihood and her life. As a graduate student at UCLA in the mid-70s, Jamison experienced dramatic mood swings that made her fun-loving and buzzing with creativity one minute and deeply despondent the next. And like many who suffer from bipolar disorders, Jamison was at first really afraid to admit that she was even sick or afraid to get the help. So despite her qualms, Jamison did seek treatment, and under the guidance of a supervision of a psychiatrist, she began taking lithium, an elemental salt that controls bipolar mood swings for many sufferers. Now, lithium wasn't magic, therefore unpleasant side effects, and in truth, Jamison missed the mania sometimes, the surge of raw energy that made her feel unstoppable, invincible, just electric. Sometimes Jamison even stopped taking the medication, only to find that without it, her life would quickly spin out of control. As difficult as it was, Jamison eventually realized that in order to continue working and living, she needed to continue testing her illness. Treatment allowed Jamison to continue her pursuits as a researcher, an author, and a professor in the field of psychology. Her book, Manic Depressive Illness, is a classic textbook on bipolar disorder, which was chosen by Time magazine as Hero of Medicine, and she was, in 2001, a MacArthur Fellowship recipient. Jamison has dedicated her life and career to unlocking the mysteries surrounding mental illness, helping countless others who suffer in the process. Jamison's recovery from and maintenance of her illness, in addition to her long list of professional accomplishments, is a testament to the belief that with proper treatment, people who suffer from psychological disorders can take their lives back. So we're going to start by asking ourselves, what is psychotherapy? Psychotherapy is a systematic interaction between a therapist and a client that applies these essentials. The first essential is a systematic interaction between the therapist and the client. So that's first. It's systematic, so there's a strategy. 2, there's psychological principles, and these are based on theory and research. 3, thoughts, feelings, and behaviors are the focus. And then 4, looking at psychological disorders, the adjustment problems, and the personal growth are the focus in an effort to help the client reach their full potential. Now, therapies have had a bumpy road to get to where we are today. Now, let's look at some of the histories of therapies. Now, the history is rooted in the assumption on demonology. In other words, possession by some demon. Now, as you can imagine, that's going back a fair ways. We don't have that same perspective today. And as such, the treatments were just less humane than they are. You'd go through exorcism, or even be executed, or put in prison, or just roam the streets without any support. Likely, these people died early. There were asylums. These were the first institutions, and they were built for warehousing, not treatment. So not much different from a prison. They would have been overcrowded, noisy, and rife with diseases. Bedlam is a word you may have heard, bedlam, B-E-D-L-A-M. It's a wild uproar, and it's derived from St. Mary's of Bethlehem. That's a London asylum from 1547. That's where that word comes from. A more humanitarian reform began in the 18th century in Paris with a Philippe Pinel at the La Bicêtre Hospital. Patients were unchained and treated with more kindness and freedom. It was William Take in England and Dorothea Dix in America that pushed these reforms forward. Asylums played a central role in Canadian healthcare until the end of the 19th century. Now, mental and general hospitals, so mental hospitals and general hospitals in Canada, mental and general hospitals in Canada gradually began replacing asylums with a focus on treatment, not warehousing. The community mental health movement attempted to maintain new patients as outpatients and to serve patients who have been released from mental hospitals. Now we can start reviewing the different perspectives on therapies, and we're going to begin with the more traditional psychoanalysis. Psychoanalytic therapies, they're based on thinking based on Freud's work and assumes that psychological disorders reflect early childhood experiences and internal conflicts. The focus is on a shift of the psychic energy from among three psychic structures. And if you remember, we went through the id, the ego, and the superego. Now, the more traditional psychoanalysis, the aim is to provide the insight into these conflicts that are causing the person's problem. And it could extend for months or even years. Now, the term that's known as catharsis is a spilling forth of repressed conflicts and guilt, like things just come out, and that is a cathartic event. Clients can express feelings and urges that have been repressed. The focus would be to replace impulsive behaviors with more functional coping behavior. One term used was free association, and Freud found that the hypothesis, or the catharsis, allowed clients to focus on repressed conflicts. However, others found that free association, where the client is made comfortable and asked to talk about anything that comes to their mind, ultimately, the kinds of issues one needs to talk about can be released with unedited free association. Now, not everybody is able to free associate as easily, and so there is some resistance that occurs when clients may not talk about threatening ideas. The ideas are repressed, so there were two other areas of interest Freud had, and one was known as transference, and the other was dream analysis. In transference, it's where clients respond to the therapist with the attitudes and feelings that they have towards people in their lives. Now, your therapist isn't somebody who's in your life like an acquaintance or a friend, but then you start to treat somebody that way who is your therapist. They're not your friend in the same way as friends are. Perhaps instead viewed as a friend or a family rather than the patient and therapist. Now, Freud felt that often clients enact their childhood conflicts. So dream analysis became what Freud believed, that dreams were the royal road to the unconscious. Dreams are determined by unconscious processes as well as the events of the day. So Freud's unconscious impulses are expressed in dreams as a form of wish fulfillment from his perspective. It's important to note that. Now, along with the psychodynamic therapy are these short-term dynamic therapies. They're briefer and less intense, but the focus is on revealing these unconscious materials and breaking through defenses. The client and the therapist usually sit face to face, rather than having the client lie on the couch, which was a traditional sort of Freud perspective. The therapist is usually directive, and usually more focused on the ego and less emphasis on the id, or the unconscious. Now, the more modern psychoanalysis are sometimes referred to as ego analysis. We'll use the Interpersonal Psychotherapy, or ITP, where it focuses on the client's relationships rather than on their childhood experiences. It usually lasts no longer than 9 to 12 months. Anxiety and depression occur within social relationships. ITP attempts are made to alleviate anxiety and depression directly. Now, a humanistic approach, we'll call humanistic therapies, here the focus is on the quality of the client's subjective, conscious experience, so their own point of view. And the focus is on here and now, not the past, not the future. Client-centered therapy, removing roadblocks to self-actualization. The client-centered therapy is intended to help people get in touch with their genuine feelings and to pursue their own interests, regardless of other people's wishes. People have an inborn tendency towards growth from the humanistic perspective. Clients are free to make choices and control their destinies. Now, psychological problems arise from roadblocks placed in the path of self-actualization. Client-centered therapy is non-directive. The clinician isn't directing things for the client, and the focus is on helping the people or helping the client feel whole again. The therapist creates a warm atmosphere that encourages self-exploration and self-expression. The therapist does not tell clients what to do, but helps them arrive at their own decisions. To achieve this, the therapist has the following qualities. They incorporate unconditional positive regard, empathetic understanding, genuineness. Those are 3 important elements of humanistic therapy. If we move to the Gestalt Therapy, getting it all together, now if you remember Gestalt if you were in my class in Psych 1, Gestalt is about bringing small things all together to make the whole. Gestalt therapy was originated by Fritz Perls, and the approach assumes that people, disown parts of themselves and don't and don these social masks, pretending to be things that we're not. The goal is to integrate these conflicting parts of our personalities. The focus, again, for this group, Gestalt, is here and now, not the past and not the future. Gestalt therapy is highly directive. People are free to make choices and to direct their own personal growth, yet the Gestalt therapy will lead the client through a planned set of experiences. Moving to behavior therapy, this is also known as behavior modification. It focuses on what people do. It applies the principles of learning to directly promote desired behavioral change. Behavior therapy uses principles of conditioning and observational learning, and this helps clients acquire adaptive behavior. So we'll use an example. So how do they handle fear reduction methods in therapy? Well, one of the techniques is what's known as systematic desensitization. And this is a method for reducing phobic responses. The client learns to handle increasingly disturbing stimuli while anxiety is being counter-conditioned. Now, counter-conditioning occurs when a response that is incompatible with anxiety is made to appear under conditions that usually elicit anxiety. Feared objects are arranged in a hierarchy according to their ability to trigger anxiety. So if I'm fearful of spiders, maybe seeing a picture of a spider is really low anxiety producing for me, whereas having a spider on my hand is very high. So we start very low and pair anxiety reduction with the image until that produced no anxiety. And then we up the scale and we up our training. Now, a second technique is known as virtual therapy, and it uses an elaborate equipment to present and arrange fears. The equipment is what's doing it. Using a systematic desensitization, the fears are reduced. Now, there are some interesting examples of virtual therapy in your textbook. Have a look. A third approach is what's known as flooding. Flooding is challenging for some. However, it can be a very effective approach to deal with fear. The individual is immediately exposed to the fear stimulus at full intensity, and as you are imaging or imagining, should you have fear of spiders, you end up with a spider placed on your arm. That's flooding. Now, you will usually, in these approaches, get a lot of support on managing your anxiety while that spider's on your arm. Now, as you can all probably imagine, some of these experiences can produce a panic attack. After the panic fades, the individual learns that the feared stimuli didn't actually harm them, even at full intensity. Now they are less afraid of the stimuli at normal intensity. A fourth strategy is known as modeling. And we've used this term in the past. It relies on observational learning. And here a client will observe a model who is dealing with the fear object. Modeling therapy results can include an increase in self-efficacy. Now, our next behavioral therapy technique is known as Aversive Conditioning. It's a controversial procedure in which painful or adversive stimuli are paired with an unwanted impulse. Now, some of you may have had this experience, I'm not sure, but there are drugs that can induce vomiting upon drinking alcohol to encourage people to stop drinking. Or my mom used to put nail polish on my fingernails to avoid my biting my fingernails. It's a bad taste in your mouth. Rapid smoking is another aversive conditioning method designed to help smokers quit. Smokers will inhale every 6 seconds or have a smoke blown in their face while they are smoking. Sounds pleasant, I know. Now, this next therapy is based on the foundations of behavioral approach, and it's using operant conditioning procedures. We tend to repeat behavior that is reinforced positively. Behavior that is not reinforced tends to become extinguished or disappear. Now, the token economy is a strategy where it's got a long history with behavioral approaches. You'll see behavior or token economy systems used in schools and group homes, psychiatric hospitals. Patients must use tokens. Tokens can be any little thing that you collect and can cash in later. Tokens are reinforcements for productive activities. So for meeting a certain behavioral criteria, a pro-social behavior, one would earn a token based on either amount of time or number of exhibited behaviors. At the end of the day or the end of the week, depending upon the program, you could bring your tokens for a reinforcement, a primary or a secondary reinforcer, and that's what you would cash them in for, so you've earned a reward for pro-social behaviors. The operant conditioning method is successive approximation and is often used to help clients build good habits, gradually working towards a goal, rewarding for each step accomplished. You know, you may have tried this before. I have in the past, and it's called Biofeedback Training, BFT. It helps clients become more aware of and gain control over various bodily functions once thought to be beyond our conscious control. You know, our heart rate, blood pressure, brain waves associated with relaxation can be a very good way to become more self-aware of your physicalness and the experiences that you're having, and to manage those experiences in a healthful and a positive manner. That's the first part of therapies. Next week, we're going to have part 2 of therapy. So look forward to seeing you then. Bye for now.